Hello and welcome to Talking Meds, a podcast from Prescribing, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, medicine's clinical advisor here at Prescribing. Hello and welcome to the latest episode of Talking Meds. I'm joined today by Zoe Girdis. Zoe is a pharmacist prescriber who works now as an independent consultant in primary care and as a trainer and educator. Zoe's career started by winning a scholarship for an economics and law degree. So that's right. You actually used to get paid for education back in the day, didn't you, Zoe? And then you changed to pharmacy. Zoe's career as a pharmacist spans over 27 years, working in England, Ireland, Australia. She's one of the first pharmacist prescribers in the UK and has now proudly done over 40,000 consultations, so an extremely experienced prescriber. She's also worked for NICE and for a time went back to Oz to work as the National Director for Practice Policy and Regulation, trying to help Australia move forward with pharmacist prescribing, nearly 18 years after we did it first in the UK. Zoe co-founded and then delivered the National Polypharmacy Action Learning set 3-day course, which was one of the best programs that I've been involved with in the last 10 years of my career. Hones in on very much on Zoe and I's shared passions around shared decision-making, person-centered care, and educating and mentoring colleagues to create those successful communities of practice that work so well in helping people learn and share their experiences in order to be the best clinicians that we can. She's also the creator of the Prescribing Mastery series. Now, hopefully people have listened to the Prescribing Mastery series, and if you haven't, now's your chance. We'll put links in the show notes to it. But essentially, these are designed to help pharmacists and pharmacy technicians add value to their roles in the community and in general practice settings. So anyone who's been to any of my information mastery workshops and always read anything about information mastery, to stay up to date in an efficient way, you need three things. You need a hunting tool, you need a foraging tool, which is alerts you to new stuff when it comes out, and you need to hot sync your brain every 6 months or so with what's new and important in your area of practice, in your scope of practice. So stuff from NICE or the MHRA or the BNF or in terms of policy, those trusted sources of guidance and recommendations. And we hot sync our brain every so often so that what's in our brain is in tune with what the latest guidelines say. Because if you don't do that, chances are you could be out of date and practicing according to how you've always done it, but it might not be in line with the best practice now. So that's what we're going to do here. We're going to do a quick update on what's new and important in the last few months from NICE, MHRA and others. So Zoe, that was a lot from me. How are you doing today? Are you okay?
I'm great. Thank you for that lovely introduction. Went on a bit of a reflective journey then. It's been a long career, so thank you for reminding me.
Yeah, a long career where you've achieved lots, and it's proud to celebrate that and as you say, reflect on that from time to time. So Zoe, what are we going to talk about today? Then what are the hot topics?
Thank you. So we've just been looking at what has come out in the last few months, primarily over the summer, where people tend to take a bit of a break. We're going to talk about the MHRA update around how we label steroids, topical steroids specifically, and then delve into a bit more of the controversial areas of the NICE heart failure guidance and the NICE draft diabetes update guidance. So I think it's going to be a bit of a buffet. We're not going to be able to cover everything in half an hour, but as long as you're aware of these, we will link the resources to the podcast afterwards. We also covered this in the last Prescribing Mastery 1 hour session. So if you wanted a bit more information on these, you can go to that as well.
Yeah, so we're going to cover the headlines here. All of these topics are high profile primary care topics. Use of topical steroids in eczema and psoriasis and other skin conditions, and diabetes and heart failure. Crikey, I don't think you can get any more sort of high profile than that. The innovations in the last few years and the changes in the last few years, it's really important, isn't it, that people keep up to date with that. Are you happy to move? Should we move on to the topical steroids quick? So this is from the MHRA, isn't it? The Drug Safety Update.
Yes, and this first hit our radar back in May 2024. But the reason we're highlighting is it was meant to be implemented by July 25. So again, you may have missed this over the summer. And this is about new labeling for topical steroids. And we specifically packaging needs to display the new potency on the label. So is the steroid mild, moderate, strong, or very strong to simplify counseling? And the reason that this has come about is for a very rare but reported reaction that can occur after long-term use with some of the moderate or stronger agents, and this is the topical steroid withdrawal reactions. And symptoms of this can include things like intense redness, burning, stinging, spreading beyond the original area that you were meant to be applying this to. So we, as pharmacy teams, we absolutely have a role in this space to use the lowest effective potency for the shortest duration of time, to tailor potency to the site, and give clear advice about how much we should use, how often, when to use it, and when to stop. And I think the when to stop doesn't happen in routine practice in the way that it should do. Also, if you do suspect the topical steroid withdrawal, TSW reaction, this needs to be, obviously, you would change your option that's available for the patient, but you need to report it via the yellow card system. So again, we can start getting a database as to how many people this affects and what this looks like.
Okay, yeah, thanks for that, Zoe. So I was always struck by how useful the fingertip unit was as a way of measuring how much to use. And you see illustrations depending on what part of your body's affected. Yeah, the number of fingertip units that you used. I thought that was a game changer when that came out quite about 20 years ago when I first saw it, but really, really useful. So this is interesting, isn't it? So that labeling of packages. So we've always thought about categorizing topical corticosteroids as sort of like mild, moderate, strong, very strong, haven't we? It's interesting. I was just looking in the BNF this morning, and the BNF still uses mild, moderate, potent, and very potent rather than strong. So it's just for people to be aware that there is a difference there. There's still the same categorization, but they use a slightly different terminology. And I've no idea whether that's going to change in the BNF to be in line with that or not. I suspect it probably will be, but just so people are aware it is different.
I think the fingertip units that you mentioned, again, our role here could be around counselling, something community pharmacists can also do in this space. So think about when the medication was started, when the stop or review date is. Think about stepping down to a weaker potency product or an emollient if the patient has healed sufficiently. And I think it's also our role to highlight some of the safety elements. So watch for skin atrophy, striae, and really make people aware that very potent, prolonged use of these medicines are not recommended. Despite the fact that they are topical, people think topical is always safer than oral. And we know that this isn't the case in this particular situation, especially when you're using those more potent steroids.
I think the only other thing I'd add there is that so the TSW, the topical steroid withdrawal reactions, the MHRA are still monitoring that. So if you do have anyone who has a TSW reaction, a yellow card report, please, into the MHRA so that they can, maybe they'll be continually evaluating this, and it may well be that they need to change the guidance depending on how many yellow card reports they get. So it's really important that clinicians are looking for this, and if you see it, please do report it. Okay, brilliant. So let's get on to some nice topics, shall we? Heart failure first, Zoe?
Yes, let's have a look at heart failure. And I will highlight that the Talking Medicines podcast that you did with Dr. Lucy Pollock are brilliant in this space, because I think this is a space that people worry about, people are confused about, people have an impression that, the four pillars are the be all and end all, and we forget about the patient that we've got in front of us. And I've had some personal experiences of patients that have been prescribed medicines to a checklist formulary, and unfortunately they become very symptomatic in terms of postural hypotension, falls, not being able to deal with life on a day-to-day basis, and their quality of life significantly deteriorates. So I think we just need to, again, have the patient at the heart of this guideline. The guidance is very good at actually, again, highlighting that this is an individualized approach. But I think some of that nuanced detail gets lost when people start seeing what the recommendation is. So when you're treating people with newly diagnosed and pre-existing heart failure with reduced ejection fracture, then the treatment combinations are offering an ACE inhibitor, a beta blocker, a mineralocorticoid receptor antagonist, and the sodium glucose co-transporter 2 inhibitors, the SGLT2s. To people with heart failure, this is for people with reduced ejection fraction. So this is different to preserved ejection fraction, which we go into detail on the Heart Failure Prescribing Mastery series. The other element to consider is for people on the maximum tolerated dose of each of those 4 medicines who continue to have symptoms of heart failure. Consider switching the ACE inhibitor to the ARNI. Now, the only ARNI we have available is the Entresto, the sacubitril and valsartan combination preparation. And NICE talk about alternative treatment combinations if certain medicines are not tolerated. So giving us some options there. This is more in line with the European Society of Cardiology guidelines in heart failure. So it synchronizes with consistent messaging, which sometimes gets lost when people are following different guidance.
Yeah, I was just going to make a comment there. There's a couple of things. I think completely right. I thought the comments that Lucy Pollock made on heart failure, I think we did 2 podcasts, one on preserved ejection fraction and one with reduced ejection fraction, were absolutely spot on and in line with what you've just said. It's about individualizing therapy and making sure you take into account what really truly matters to the person, how old they are, what their personal circumstances, etc. are. Andy Hutchinson and I talked about this on the podcast, the lost guidelines from NICE. Every one of these recommendations is written within the context of the guideline on shared decision making, the guideline on multimorbidity, and the boilerplate text at the front of every NICE guideline that basically says you should be individualizing this. There is nothing mandatory in these guidelines. They're a representation of the best available evidence, and these are the best options that you have available, but you need to explain the risks and benefits to people so that they can make their own decision about it. So the next question, I guess, is, right, how do you explain the risks and benefits to an individual? And NICE haven't done a patient decision aid on this yet. I don't know if they've got plans on doing that. But what we do have is GP evidence from Julian Treadwell, don't we? So gpevidence.org, I think it's one of the best websites out there. And if you want to see how many people out of 100 who are, where they have sacubitril and valsartan and they've got left ventricular function of 29%, and you want to see how many hospitalizations for heart failure that prevents, out of 100 people who are all given that combination, 3 out of 100 will be prevented from going into hospital with heart failure over 2.25 years. Now, for some people, they might think that's quite a lot. Yes, I'll take that, please. And you need to explain the harms to me as well, and the risk of the side effects with taking that combination, such as postural hypotension, for example. But somebody else might say only 3 out of 100. Oh, well, do I really need to take another tablet then? Well, I've got other priorities here so it's not our decision to make as clinicians. Our job is to explain the risks and benefits of the options to the individual after we've found out what really matters to them, and then take it from there as to the best option for them at that point in time. And that's what NICE is saying in this heart failure guideline, Zoe, aren't they?
Yes, they are. I mean, there is an emphasis on the 4 pillars at an earlier stage when the person is symptomatic, because if you're a patient, it's easier to take something that is going to improve your symptoms, not necessarily something that's going to improve the disease-oriented outcomes that we often talk about, the do's versus the poos, the patient-oriented outcomes. Am I going to have a decreased chance of going to hospital? Am I going to have less nighttime wakings? These are things that matter to patients. So we need to be cognizant of that when we're discussing with them, the benefits, the risks, the alternatives, and doing nothing. And GP Evidence is a really good website that can visually inform our patients make these really difficult decisions, and we're there to support them in answering any questions. I would also like to say that we shouldn't be driven by numbers and QOF alone in this space. This is about treating the patient, making sure their symptoms are being well managed. And we do have that personal care adjustment and exemption that is available in most QOF. So document that you've had an informed discussion with the patient, what the patient has decided, how you've made that decision together, looking at the benefits, the risks, the alternatives, doing nothing, and taking into consideration their IDs, concerns, and expectations. So I think that's really important in this space. And also use the MDT, which is another point that NICE allude to. What does your MDT look like locally? Do you collaborate? Do you communicate? Really basic things, but things that we don't do in a busy working day because we don't have time, or we forget, or we're distracted by 10 other things that happen by the time we think about doing that, and then the next thing that evolves. So information we should be giving to our patients, making sure that we're clear about treatment options, care plans, counselling, support needed. Sick day rules are also mentioned in the guidelines. And one thing that I think a lot of people have missed is the do not restrict salt and water intake over and above the recommendations for general health. And as Lucy Pollock says, it just makes life miserable beyond other things. So just wanted to highlight that element as well.
No, completely agree. The implementation gap here is at both ends. There is both over-prescribing of heart failure medicines and under-prescribing of heart failure medicines. And that's the challenge, I think, for all of the multidisciplinary team to try and get that balance right, making sure that we're finding people who are symptomatic, where we can really help them, but also not being, well, making sure that we're patient oriented at later stages of people's lives as well.
Yeah, and I think, this is really challenging. We can't predict the individual's patient journey that we have in front of us. We can't do this in silos. We need to do it as a multidisciplinary team. It is guidelines, not tramlines. So we need to be aware that the patient in front of us may not be represented, and often isn't represented, in the clinical trials that use to drive evidence from a population health perspective. We need to be educating and empowering our patients through shared decision making. And we need to think about those 4 pillars in, well, when is the most appropriate time for this patient? Why am I doing this? How can I do it in a very tailored way to the patient I've got in front of me? So we've got a huge amount of opportunities in this space. And yeah, I think it's an opportunity if we do it safely.
Fantastic, thanks for that. So that's the update to the heart failure guidance from NICE, which is actually that's in action now, isn't it? And they've labelled on the guideline which recommendations they've updated in 2025 and which ones stay the same. What we're moving on to next is a draft update from NICE, which is on the management of type 2 diabetes. So it is still draft. It was described, wasn't it, in my friends at the NICE communications team as the biggest shake-up in type 2 diabetes care in a decade. So that sounds quite big then, Zoe. What's happened? What do they say?
I think they're saying what most good clinicians do, and that is moving away from a one-size-fits-all approach. The evidence has changed, so therefore guidance has changed. But this is a real personalized first-line choice for patients. And we need to individualize this based on other things that are going on for that patient, the cardiovascular disease, chronic kidney disease, weight priorities. What else is it that is increasing the risk of heart failure, heart attacks, strokes, all the things that people worry about? So it does talk about earlier use of SGLT2 inhibitors, the gliflozins. It's moved from second line to a first line option along with metformin. And this is to protect heart and kidneys beyond the just controlling blood sugar level. Again, most of us that have been around for a long time will remember the days when diabetes management was a very glucocentric approach to care. And as we know now, that's a disease-oriented outcome. We need to be focused more on the patient-oriented outcomes, living better, living longer. So you can use now the SGLT2s when metformin is unsuitable or contraindicated, or when the cardiorenal benefit is paramount. So those CVD, CKD, weight priority patients. GLP-1 receptor agonists, the dual agonists, these are now being considered earlier when weight loss or ASCVD risk is high. And you need to continue to follow the technological appraisal criteria. Things like tirzepatide would be included in this space. And I think it is important that NICE does highlight, again, reinforce HbA1c targets and shared decision making that's very personalized. So for an old person, and the NICE patient decision aid on diabetes that was alongside the previous guideline was brilliant on this. You could send the link to the patient. I think it was page 11. I'd often send it to patients and say, fill this out before you come and see me. And it really helped patients focus on what matters most to them. Is it that they don't want to be going to the toilet as frequently? It's stopping them from going out first thing in the morning. Is it that it is really important to them to have good sugar control because they're younger and they don't want the long-term consequences of diabetes earlier in their life? So I think the biggest shakeup probably refers to the fact it's a very personalized approach. We're doing this earlier for patients to help them live better and live longer. It is a real focus on prevention. So a shift from managing just blood sugar levels to preventing those serious complications before they occur. And this fits in line with the NHS 10-year health plan when we look at prevention, and also does allude to the digital and community-based care, again, dovetailing in with the NHS 10-year plan, which supports the use of continuous glucose monitoring and the expansion of community-based care models. So I guess my question to Jonathan, having lived NICE for nearly 2 decades, do you think that NICE are going to start bringing the 10-year plan into all drafts as we move forward? Because that's also a change that we've noticed, tying in the policy element.
Yeah, I mean, I'd be amazed if they weren't. NICE has always had a close relationship with, whilst being arm's length, with the Department of Health and NHS England. And it would be, I mean, it would be madness for them not to take into account the priorities for the NHS as indicated in the 10-year plan. NICE are mentioned in the 10-year plan quite a lot. I think the 10-year plan relies on NICE to do things a bit differently, to be able to achieve what they want to achieve. And I think you're right. I think the type 2 diabetes guideline update probably is a reflection of that. It's interesting though, because I remember teaching about type 2 diabetes years ago, and we used to use the hand, Zoe.
Yes,
So you'd
I
hold
do.
your hand up and you'd say, right, what are the things that what the options here? And you'd say, stop smoking, use metformin, get your blood pressure under control, lifestyle advice, and the little pinky finger was tight control of blood glucose, wasn't it?
It was.
And you wouldn't prioritize that. You do the other things first. That's the thing that comes across and came across really well in the patient decision aid that NICE did at the last iteration of the update. And it was page 3 where you've got a lower HbA target might be better for me, or a higher HbA target might be better. And you get to point on the graph where you sit, what's important to you, what matters to you. It's everything we've been talking about. So if hypos are a big problem for you, hypoglycemic episodes are a big problem for you, then that would be deprioritizing some of those medicines that can reduce your HbA1c, but potentially increase your risk of having hypoglycemia. You might not want to take any more medicine. So actually having a slightly higher HbA1c target could be absolutely appropriate for you if you haven't got any symptoms or anything. So I really like that. The other thing that I've picked up on with the draft guideline is again, the headlines seem to be, we're not using metformin anymore, we're using the SGLT2s, and that's not what it says. Let's be clear about that. It does not say that. What it says is, have a think about the options that are most appropriate for the individual. For some, the SGLT2s might be a really, really good option for them, but you need to explain the risks and benefits to people. And again, using GP evidence, how many renal outcomes are prevented by taking an SGLT? Someone who's got established cardiovascular disease and type 2 diabetes, over 4 years, 100 people taking an SGLT will have one hospitalization for heart failure prevented over the 4 years of that. And in terms of renal outcomes, you've got one renal outcome that's prevented over 4 years. So again, it's not that you would, this isn't for everybody. And there are side effects associated with the SGLT2s as well. The urinary tract infection, potential increase and things like that, which you have to be careful about and you have to be mindful of it. It's very much a person-centered decision, this.
Yeah, absolutely. If we take a helicopter view of this and zone out for a little bit, it is, the evidence base has changed, which is why we now have the SGLT2 inhibitors, the gliflozins and the GLP-1 receptor agonists offer, that significant cardiovascular and kidney benefit beyond that glucose lowering effect. But as Jonathan has just shown you, it will be interpreted differently by different people because we all have different preferences and values. But, it is important to showcase what that number looks like for that individual patient. It's also an opportunity to address some of the disparities. So the underprescribing of some of these medicines, especially among women, older people, Black or Black British individuals, has been identified. And it is about smarter spending by promoting earlier preventative use of these medicines, and making smarter financial decisions by preventing that future ill health. That worries quite a lot of our patients. A lot of patients are getting diagnosed with diabetes a lot earlier, which, yes, we have better ways of detecting, but we're also in an environment where people are not exercising, gaining significant amounts of weight. That whole biopsychosocial model that we always talk about needs to be considered in this space as well.
Absolutely. I like what you said right at the start as well. The reason the guidance has changed is because the evidence has changed here. And there's been some recent publications of improved clinical evidence. But the thing that's changed more than anything else is the cost effectiveness evidence here. And there's nothing wrong with that. We have to spend NHS money wisely and use cost-effective options. So I would fully expect NICE to change their recommendations when the cost-effectiveness evidence changes. They wouldn't be doing their job if they didn't do that, quite frankly. So no, I think this is a really, really interesting development. I'm sure there will be lots of interest from the clinical community and others out there. I'm sure NICE are bracing themselves for a whole raft of comments on the consultation document. And you know what? We talk about this in the information mastery workshops, don't we? Where you get used to doing things in a certain way, don't you? And when someone comes along, and we have a mind line, don't we, which was described by Gabby and LeMay all those years ago. We have pictures of evidence and what we think what good practice is in our brains, and we work a certain way. When something comes along that challenges that, as human beings, we find that uncomfortable. And we look for ways to say, that can't possibly be right. I've been doing it this way for the last 10 years. And you look for ways that it's going to be wrong. And actually, a lot of the responses to the consultation will be along those lines. It'll be like, no, this can't be right. This is too difficult. We can't possibly do this. But actually, it might be the right thing to do. And we might just have to change our mind lines here.
Yeah, as long as we inform our patients about the risks associated with these medicines, the benefits, what are the alternatives available to them, and sometimes doing nothing is an option as well. So I think that really we've got the evidence does change. The evidence is for a population, but what about that individual that we've got in front of us? That is key.
Absolutely. And it comes right back nicely to where we started, asking and finding out what really truly matters to that individual person. What is it that matters to them? And how can we best achieve what really matters to you and help you get there? Zoe, that's been brilliant. It's been great talking to you. What a fantastic way of hot sinking our brains with the latest hot topics. Thanks very much for all of that. We will put links in the show notes as always, guys. Please give us your feedback. But thanks very much, Zoe, and we'll see you all next time.
Brilliant. Thank you. Bye.
We hope you enjoyed today's podcast, and we'll see you in a couple of weeks for the next episode of Talking Meds from Prescribe, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us on talkingmeds@prescript.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the Prescript website for all of our excellent resources.